Yo, yo, yo. Hey guys, welcome back to another amazing edition of the Best Practices Show podcast. Happy Friday, everybody. I hope your week has really been amazing. And on Fridays here, our job on the podcast is to keep you at the top of your clinical edge, to give you some information, to help you think better about how you take care of your patients. And today we're going to do exactly that with a regular guest on the podcast. She's become a dear friend and a powerful force in the world of dental education. Katrina Sanders. She did a masterclass for us recently called Are You Smarter Than a Periodontist? It might have been her best masterclass ever. It's so good, I thought we would share the audio on the podcast. So here it is. Please listen up. I hope you guys enjoy it, and we'll see you soon. Well, thank you guys for being here for this amazing masterclass. I have no doubt you're going to be wowed. You're going to be entertained. You're going to laugh. I say the same thing about Katrina all the time. There's very few people that can combine the education with the verbal skills, with the research, with the humor, and then she's a sommelier and wine. Like you're in a category of one. Nobody does that. I mean, it's one thing to go to a lecture and somebody's really smart and you're like, wow, that's really smart. It's one thing to go to a lecture with a lot of research going, that was great research. There's one thing to go to a lecture where somebody makes you laugh with patient stories. You're like, oh my gosh. It's one thing to hear great verbal skills, but to see them all intertwined, doesn't happen. So we're excited to have you here, Katrina. You're not only a great friend, you're from a pretty cool state, Wisconsin. So that's kind of cool. And you've become a dear friend of ours in the ACT dental community. And I'll tell you, if you haven't had her speak to your study club, what are you thinking? She's brilliant. Have her speak to your study club. She will wow them. And then if you haven't been to one of her courses, I'm going to highly encourage you do that. And we are hosting one of her incredible flagship courses. And Angela, you have all the dates. I can't remember what I'm doing today, but like
August 1st.
August 1st. And if you register today, there's a special incentive to be able to do that. You come to our world headquarters. Are you going to serve wine during that one?
I don't know.
I think it's at like 8:30 in the morning.
It's at 8 in the morning, Kirk. Calm down.
Maybe we should
Could you do mimosas? Could you do mimosas?
It's 5 o'clock somewhere.
We'd have to clear it with Chris.
We would have to. So but you'll hear all about that. And Katrina, we're just super, super grateful. So thank you so much for being here. Take it away.
Oh, thank you so much, Kirk. I so appreciate it. And I the mutual admiration that we have is just so powerful and incredible. And I just cannot thank you and the amazing folks at ACT Dental for always rolling out the red carpet for me. And as Kirk had shared, yes, I am from Wisconsin. I'm from Milwaukee. So every time I go back to the ACT World headquarters in downtown Milwaukee, Wisconsin, it just, there's something about it that just always feels like Dorothy's clicked her red heels together and she's made it home. So thank you so much. And as Angela just put into the chat box, that is the registration link for the coursework that I will be presenting this summer at the ACT headquarters in Milwaukee, Wisconsin. And one of the cool things about that course, before I dive into today's course, one of the cool things about that course in Milwaukee this summer is that I will be co-presenting it alongside my sister. So who doesn't love a sister act, right? So please consider joining me and my sister, Dr. Elizabeth Sanders, for the oral systemic myth. With that, let's dive in to, are you smarter than a periodontist? As a dental hygienist, I will tell you, I graduated from hygiene school assuming that there's no way that I could be smarter than a periodontist. And I will tell you, as a dental hygienist who works in a large group periosurgical practice, I do still absolutely have a deep-rooted respect for the incredible smarts, brilliance, education that our periodontists have. Today's course is certainly not intended to make light of the brilliance of our periodontists, but rather to kind of peel back the layers about the fact that if you are practicing in a general practice, that if you're a dental hygienist, you likely are the perio specialist in that office. And for our doctors who have really vowed and created a high level perio program in their practice, you too offer a high level extension of being able to provide incredible periodontal services to your patients. And as we really unpack the important and, in my opinion, deeply necessary care that periodontal therapy truly is for our patients, I think we have to take a step back and deeply appreciate how wildly prevalent this disease process is. So for those of you who have taken my coursework before, you know this is one of the beacon benchmark slides that I consistently present because I think it's important for us to remember that the prevalence of this disease that our perio specialists are actively treating daily, and the disease process that in general practices you are actively screening for and subsequently actively treating in those mild and moderate cases, is an extremely prevalent one. The American Dental Association back in 2016 estimated that about 47.2% of U.S. adults, these are patients between the ages of 30 and 79, have some form of periodontitis. Now, it's important to know in this population, 47.2 means that nearly 1 in 2 of your adult patients between the ages of 30 and 79 have some form of periodontitis. 1 in 2. So I want you to consider that. General practitioners, how often are you performing periodontal procedures in your clinical practice versus how often are you performing the free cleaning the patient's insurance will pay for? And I share this because, as we're going to dive into in a short moment, one of the key pieces that I deeply admire about our perio specialties is that because of the study that our periodontists have in periodontal disease, their concern about what this uncontrolled inflammation is doing, not only locally, but also systemically for the patient, means that they are far more primed and far more confident in sharing with their patients about the presence of periodontitis. Now, I know what you're all thinking. Well, yeah, of course, you're in a perio office. That perio is extremely obvious. And you'd be right. Absolutely. A patient who's been referred over to a perio practice is typically a patient who either has refractory or non-responsive perio, or a patient whose bone loss is so severe that the general practice has recognized it's out of my hands. And so, yes, we do see in a perio office the severe. The truly severe cases, the ones that are lacking control, the ones that are constantly refractory, the ones who are likely non-responsive, the ones who require advanced care, oftentimes beyond simply periodontal management, and now looking at things like nutritional deficiencies or underlying undiagnosed systemic diseases. So yes, in a perio office, we are seeing those severe cases. It's important to know that the vast majority of this 47.2% of adults who have perio, the vast majority of them, about 89% of them, are going to present with mild and moderate severities of the disease process. Only about 11% of patients who have periodontitis are considered severe. So again, it's important for us to take a step back and recognize the critical role that a general practice should have in critically assessing and subsequently diagnosing this overt disease. Now, I do promise, as my bestie Kirk had shared, to always lay down the facts and the data. So in small font down at the bottom of the slides, you will see the research where I've captured this critical data. The current landscape of periodontitis really points to the overt concerns that periodontal disease is considered a massive contributor to the global burden of chronic disease. In fact, periodontal disease is considered the sixth most prevalent disease of mankind. The sixth most prevalent disease of mankind. It's no wonder we're so busy. Now, here's what's really incredible. Prevalences of disease when it comes to periodontal conditions continues to increase. Despite the data, despite the research, despite how hard we're working to try to manage these diseases, the prevalence continues to increase. And concerningly, the prevalence of periodontitis has increased about 57% from the 1990s to about 2010. Now, that's really important because it means that although we are doing more to identify this disease earlier, we're pulling in tools from our tool belt to help eradicate this disease sooner, that along the way, we are still continuing to see heavy prevalences of this disease. And there are a lot of reasons for that. Number one, patients are living longer. And they are living longer with their natural teeth, which means that patients who perhaps decades prior would have had those teeth extracted due to hopeless prognosis and been wearing dentures by now, those same individuals today instead are managing their natural teeth with overt levels of attachment loss, or in many cases, we're seeing a resurrection of that inflammation that requires constant, prudent evaluation and subsequent maintenance. What's more, patients are living longer through chronic diseases. And the sad reality of the existing health complications, particularly in the United States, directly point to the fact that although, yes, our life expectancies are longer, we are living longer than we ever have before, with the exception of the year 2020. So if you remove 2020 from the picture, in the United States, we are living longer with all of these comorbid complications showing up. Unfortunately, if you take a look at the quality of life of Americans who are living longer, we recognize that not only are we living longer, but we're dying longer. The last several decades of our lives in the United States are oftentimes spent in chronic disease. Chronic catastrophic disease with elevated risk for cardiovascular issues, diabetic complications, complications with osteoarthritic issues. And so now we recognize that bidirectional challenge that inflammation in the mouth / inflammation in the body can create on each other, which means that we are living longer on medications to control these chronic diseases, which are complicating our oral immune system, which creates an issue when it comes to being able to prudently control these oral inflammatory conditions. What's more, oral hygiene routines across the United States have significantly declined, particularly during COVID. And those oral hygiene routines that declined now have many researchers suspecting that the previous prevalence, 47.2% of adult patients, that previous prevalence that was captured in 2016, that perhaps that may no longer be accurate, that perhaps the prevalence of early and moderate conditions of periodontal disease may in fact be far more advanced. During COVID, there were concerns of opportunistic infections, stress, wearing masks that allowed for constant recycling of diseased air, viruses, yeasts, funguses, and molds. And so part of the challenge inside of these opportunistic infections was that we suspect that there has subsequently been a rise in the level of oral disease we see in our patients. And it is important to note that during the pandemic, society was told to cover their mouth to protect their bodies. And so alongside this, we have, or rather should have, an educated patient population who understands that the mouth is a portal to the rest of the body, that infection that affects the rest of the body can be acquired through the mouth. And yet, I think one of the biggest challenges that we run into is that we consistently see patients in a perceived state of health. Put simply, our patients who sit in our chairs, hygienists, you know exactly what I'm talking about. When our patients sit in our chairs, oftentimes they lack awareness that bleeding from the mouth is not normal, nor is it a sign of health. Patients sitting in our chairs, although they will likely know and might even admit to us that they are poor with their oral hygiene habits, rarely understand that poor oral hygiene habits are linked to poor oral hygiene and subsequent poor oral health. And so part of our challenge early on in the process, when we see these mild and moderate cases of disease, is now to help educate our patients, to help them understand the sequelae of this disease process. And now as research continues to unpack layers and layers of how oral disease is linked to systemic disease, now the burden, the responsibility, the opportunity, the pleasure we have in partnering with our patients and helping elevate their health becomes even more important than it ever has. Today, in dentistry, we have an opportunity to truly position ourselves as partners alongside the medical community in prevention and in subsequent inflammation management. My name is Katrina Sanders, and it is an honor to be here. Again, I want to thank so much the incredible folks of ACT Dental for this amazing opportunity to be here today. I am a periodontal hygienist. I am a wet-fingered periodontal hygienist practicing here in sunny Phoenix, Arizona. I'm also an educator, speaker, author, podcaster, influencer. If you like what you see, feel free to follow me on social media. I'm on Instagram at the Dental WINEgenist. And I promise to always throw down fun, educational, nerdy dental content for you to metabolize. I also want to thank some amazing folks today for their unwavering support. I did receive honorarium for today's program from ACT Dental, and I am a key opinion leader and contracted speaker for PDT, BioGaia, Florida Probe VoiceWorks, Closest, and Perio Protect, whose content you will see here today. Today's coursework will help us to kind of deep dive into some of the things that our smart periodontists are helping to build and develop for us. This QR code here on this slide and or the link in the chat box will bring you to a downloadable free resource. This resource is actually a suggested protocol that has been designed by a periodontist, one of my dear friends, Dr. Sam Lau. And this resource is essentially his protocol around how to address various levels of oral inflammatory conditions, when you may integrate different kinds of modalities beyond the basic CDT codes, to consider adjunctive therapies to really help support optimal patient outcomes in the management of periodontal disease. So please feel free to download that free resource. And again, that is a protocol developed by my dear friend and periodontist, Dr. Sam Lau. Today, we will be assessing our knowledge of periodontal assessments and diagnostics, as well as explore some guidances on some futuristic or innovative approaches to treating this disease and along the way helping to optimize patient outcomes. That's what we're focused on in the provision of periodontics, is being able to swiftly and definitively address this disease process. But this course is Are You Smarter Than a Periodontist? And so today, this will be a heavily interactive, game-based program. My hope is that this will be interactive and bring you into the journey. So Without further ado, buckle up, buttercups, as we dive into understanding our critical role inside of managing and subsequently mitigating oral inflammatory conditions. So we're going to take a look at the various steps inside of the process of care. This, we all remember this from dental and dental hygiene school. This is ADPIE. This is the process of care that we all learned about, that we take each of our patients through when we capture our patients' assessments. And the assessments kind of begin that journey for us. Put simply, just because a patient is put into the Dentrix appointment column as a prophy does not necessarily mean that patient is a prophy. Prophylaxis is in the implementation phase. So while the patient may be scheduled for that, there is a plausibility, a probability that that patient may not in fact qualify as a prophylaxis. So while many of us want to start by sitting the patient down and going, "You're here for your cleaning, let's get started," the reality is we really need to begin in that assessment phase to actively track what our patients look like today. Patients in their assessment phase will present with different changes to their medical histories, changes to medications, changes to stress levels or lifestyle implications that could indicate or start to propagate early inflammatory conditions. Think about your patients who had a major medical history change, a cardiovascular event, a cerebrovascular event, a patient who is diagnosed with pre-diabetes, a patient who says, "I am now pregnant." These are patients where their display today may in fact look dynamically different from what they looked like 6 months ago. And so the assessment phase begins that journey. Then and only then can we properly move into diagnoses and subsequent planning to then identify, do we agree that this is an appropriate prophylaxis today? Prophylaxis meaning prevention? Or do we need to consider other advanced modalities in the patient case? So let's dive into these assessments. And again, it is important to recognize the critical role of the assessment phase. I'm a firm believer that while we learned about assessments in dental and dental hygiene school, and while we know how important they are, I think we can all agree, and I'm going to share something quite provocative. I think we can all agree that although we know how important these are, the reality, or rather the challenge inside of this, is that oftentimes these assessments are not receiving the critical focus that they, keyword, should in our dental practices. So every assessment phase may be different depending on the type of practice that you're in. In our office, this is the assessment phase that we walk our patients through. So we do a comprehensive medical history review, where we are looking for or sniffing out things in that medical history or patient-reported symptoms that may indicate an underlying condition. Because I want to know, does my patient's body have something to do with what's going on in the mouth? Because it turns out if there's something going on in the mouth, it may in fact contribute to what's going on in the patient's body. We look at dental history. We screen for oral cancer. And as of the recording of today's program, we are still in the month of April, which is Oral Cancer Awareness Month. Oral cancer is the cancer of our profession. If we are not screening for oral cancer, who will? And so I oftentimes hear from my colleagues, "Katrina, you don't understand. I don't have enough time to do a comprehensive oral cancer screening." And with all due respect, based on the severity and the seriousness of oral cancer and the prognosis of a patient, if we do not identify it early on, respectfully, you don't have time not to do an oral cancer screening. Then we dive into our perio charting. We leverage the use of our radiographs, and we do conclude with evaluating our patient's oral hygiene status. And, you know, your perio charting may look different depending on the type of patients that you're seeing. In a perio office, not only are we capturing things like pocket depth and subsequent bleeding points, but we are also capturing things like advanced recession, furcations, and mobilities. Because yes, in our office, about 99.99999, that's a number I made up, percent of patients in our practice have clinical attachment loss. Every once in a while, you'll get that one patient who's 14 years old who needs a frenectomy. We could say that patient is not a periodontally diseased patient, but the vast majority of our patients, we are capturing all of these assessments. We are also looking for gingival assessments. We're looking for changes in the tissue that could indicate activity of the disease process, like color, contour, texture and consistency, or gingival enlargement, patient-reported oral malodor and pain, and then even comprehensively assessing the deposit of our patients, looking at the presence of calculus, food impaction, stain, etc. So this perio charting piece becomes really important, but we know that there are challenges inside of comprehensive perio charting. So here begins our very first game in the game show of Are You Smarter Than a Periodontist? And that is fear factor. So I'm going to ask you all to get out your phones, because we are going to begin with this very fun, I call this a Kahoot. So this is a game. It's going to be loading quite shortly. Oopsies, hang on. Let me make sure that I got this. Okay, so it's loading right now. And when you see me hit start, you're going to see a QR code. I'm going to have you go ahead and scan this QR code here with your phone. And this QR code is going to allow you to enter into the game. We are going to be playing a lot of fun Kahoots throughout today's program. So I want you to keep your phones on, ready, and available so that you can participate in this super fun game. Of Kahoot. For those of you who are familiar with Kahoot or you've utilized Kahoot before, you should maybe even have the Kahoot app where you could just insert that game pin. So this is Fear Factor. For those of you who remember how Fear Factor works, it was people joining this game where they had to do like really scary things. And if you've watched the show, you've seen them do really weird things. Like they have to, sit in a glass tank with spiders and snakes thrown on them, or they have to do scary things from heights. So talking a lot about their fears and working through and overcoming or achieving strength inside of their fears. So let's take a look. And this is going to be a poll. I want to learn from you about would you rather, which is scarier, or which would you rather do of these scary scenarios? So let's get started, friends. This is Would You Rather. This is the Fear Factor version. All right. So here we go. Are you smarter than a periodontist? Fear Factor. This is a poll. So the first poll is going to ask, would you rather spend the entire day charting 6 millimeters on patients with a probe that has lost its markings, or chart a patient who is so chatty that every time you type in the numbers, they're talking? Oh, I'm just getting a chill thinking about this. Which would you rather have to deal with? Charting with a probe that's lost its markings, or a patient that's so chatty every time you type in the numbers, they talk? It looks like about 53% of you said you'd rather have a chatty patient than a patient, for example, or a charting experience where that probe has lost its markings. All right. Second question. Would you rather? Okay, let's take a look at this one. Would you rather have to put a bleeding point in for every single site, or would you rather have to chart mobility on a patient? Which would you rather? This patient has generalized bleeding, so you got to put bleeding in everywhere? Or would you rather have to have a patient that has mobility where you've got to chart that? Oh, it looks like 67% of you would rather chart mobility. Wow, interesting. All right, let's take a look at this one. Would you rather chart a patient who ate garlic before the appointment, or be required to chart with a pen and paper in a dark operatory? Ooh, for the vampires, in the room, I'm sure you're going to pick the blue one, but would you rather chart a patient who ate garlic before their appointment or chart with a pen and paper? Yeah, I think most of us would rather take the garlic patient, right? Yeah, for sure. We all remember the days. Do you all remember that red blue pencil that we had to use? I always say kids these days will never know what it was like to have to saran wrap a red blue pencil, right? Oh, it just cracks me up. So let's take a look. Here's a quiz. Ooh, the average percentage of recare patients who currently have updated perio charting in the average dental practice. So in large chart audit studies, they found that recare patients, when we take a look at how many of them have updated perio charting, what is the percent of those patients that have updated perio charting in their chart in an average perio or general practice? Yeah, 20%. You guys, this is crazy. The average, when chart audit studies are done, the average amount of patients in that practice who have updated perio charts, and that means a perio chart done one time a year, is 20%, which is crazy. That means the vast majority of our patients who are in our recare system do not have updated perio chart within 1 year. Marie on the board. I love it. All right. Next quiz question asks, of the patients with perio charting, what is the percentage of those with bleeding points noted in the chart? Now, this is bleeding points in the perio chart. I'm not talking about in the clinical note that says generalized moderate bleeding. How many of these patients that have perio charting have bleeding points put into the perio chart? What percentage? Yeah, 13%. 13% of patients who have perio charting have bleeding actually notated in the perio chart. The rest of those patients don't have any bleeding notated in the actual perio chart itself. Maybe there's a notation in the narrative, which means that the perio chart itself is not a comprehensive survey of the display of our patients. Last one. What is the most common reason complete perio charting is not always captured in dentistry? What do you think is the most common reason? Is it we don't have time? Is it because the patient declines the perio chart? Is it because we're not trained in how to do it? Or is it because we lack proper equipment for assessments? What is, in your opinion, the most common reason why perio charting is likely not done in most dental practices? Yeah. I'd agree. Look at the vast majority. 89% of you said it's a lack of time. We don't have the time, which is truly incredible when you think about it. Well, a hearty congratulations to Moosey AH in third place, in second place, Kristen, and in first, I'm going to guess this is Oh, Josh. Very nice, Josh, you with your bald eagle there. I love it. That is awesome. Well, congratulations to our winners. And again, thank you so much to those of you who participated in this. I really do appreciate it. Stay tuned because we will have tons more of those guys coming up just in a short moment. All right. So let's dive a little bit into what we understand about perio charting. Yeah, I get it. The vast majority of us say that our biggest challenge is we don't have enough time to complete it. And I think alongside that, we don't have enough time to complete it means that we don't have enough time to set up all the things that we need to in the software, that there's a lot involved with actually doing the comprehensive assessment and then notating it, mouse clicking. For hygienists that do not have a dental assistant, it makes things even more challenging and complicated. So one of the cool things that we're starting to see really entering the scene in dental practices, and particularly those dental practices where the doctor practice owner is focused on getting comprehensive assessments and helping the patient understand the severity of their disease so that the patient accepts treatment, is the use of hands-free charting, which, by the way, does not require hiring a dental assistant and paying a dental assistant hourly salary to do. In these instances, hands-free perio charting like you see here from my friends at VoiceWorks, Florida Pro, is a beautiful way for technology to step in and help us to streamline perio charting. This is a voice-controlled perio charting software. And what's cool about it is this software actually bridges with your existing practice management software. And it does allow us the opportunity to perform perio charting in full PPE. So this headset can be worn underneath your full PPE, including the shield, for those of us who are still wearing the shield. Here's the cool thing. If you wanted to try it out, they have a 90-day money-back guarantee. So if you wanted to try this out, you could go ahead and get the equipment in your office. You could try it. It's a subscription-based model. So you pay a monthly subscription fee. And if you hate it after 3 months, you send it back and you get all of your money back. So it seems like a really neat no-brainer. I want to show you a little bit more about how this technology actually works. On the next slide, you're going to see a video of a hygienist utilizing this software. And if you have any interest in connecting with them to learn more, there'll be a QR code on this slide for you to scan to learn more.
324.
3-2, warning, 4.
Bleeding.
Bleeding.
Interproximal plaque.
Interproximal plaque.
435.
Warning, 4. 3, danger, 5.
Exudate.
Pus.
Interproximal bleeding.
Interproximal bleeding.
Facial recession 2.
2.
Jump to 2. Open. Mobility 1.
Mobility, 1.
Jump to 7. Mobility 2.
Mobility, 2.
Jump to 3. Buccal furcation 1.
Furcation, 1.
Distal furcation 1.
Furcation, 1.
Generalized interproximal bleeding.
Generalized interproximal.
Look at that, generalized interproximal bleeding. We're done.
3, 2, 3.
Interproximal bleeding.
Interproximal bleeding.
3, 2, 3.
3, 2, 3.
Jump to 5. Half tooth hyperplasia 1.
Half-tooth hyperplasia. 1.
Voice works off.
Now, how incredible that this software allows us to be able to jump back and forth and to load comprehensive information. And this is the crazy thing. You'll capture a complete perio chart in under 7 minutes. And by complete, I mean complete periodontal probing. You're capturing bleeding, suppuration, recession, furcations, mobility, and even capturing things like deposit level, as you heard the provider share, interproximal plaque. So now we have an opportunity to capture a more compelling and more comprehensive charting system, which we know is extremely important for helping our patients and our third-party payers understand that level of disease. So again, something to consider, an amazing way that I, in Perio, am already capturing this information. And it really is one of the opportunities that sets us apart, I believe, in Perio, is being able to capture this information. Another challenge that we do see when it comes to capturing assessments, though, is that I think a lot of times we believe that we are super gentle when we perio chart our patients, and we don't ever cause pain for our patients. And usually I'll ask, how many of you think I'm a super gentle prober? My patients always say, wow, that was super gentle. Well, part of the challenge in this actually is that when we've done research studies of pain perception, how patients experience uncomfortability during probing, it actually indicates in a lot of research studies that a large portion of patients who receive perio charting demonstrate significant pain. They're not saying anything, but they are uncomfortable. They are white knuckling on the chair, which indicates the fact that we actually do not do a very good job of appraising the level of pain or discomfort that our patients experience. Now, that becomes really important because one of the challenges that we recognize in probing patients is that if they are uncomfortable during the perio probing process, I think a lot of patients think that we are intentionally causing them pain and trying to make that 5 or 6 or 7 millimeter probing depth. So I think it is valuable or important for us to recognize that patient comfort, or rather the lack of pain perception, is an important tool in supporting our patients in success. So this is a research study that was done, and this QR code will actually take you to the page where you can explore this probe. See what I did there? It's not an explorer, it's a probe, where you can learn more about this exact probe. So there was a research study done that looked at which of the probes provides the greatest patient comfort when calibrated studies are done. And it was noted that the UNC 12 probe provides the greatest patient comfort. The other nice thing about the UNC 12 probe is that it has pretty consistent probing markings. So you are able to assess what a 1, 2, 3, 4, 5, 6, all the way up to a 12 millimeter probing depth would look like in a patient. So it allows for better consistency and more reliability between providers when they are utilizing a UNC 12 probe. So a really terrific opportunity there. So yes, our assessments are a critical aspect of the journey. And we know along the way that radiographs do help. We know that being able to take a look at radiographs gives us the opportunity to evaluate interproximal bone. Although data now is actually pointing to the fact that early clinical attachment loss can't be seen on x-rays, that your early stages of disease, your mild and moderate cases of disease, are likely not going to be seen radiographically, which I know is a challenge because a lot of our third-party payers are looking for radiologic bone loss. It is important to remember that the definition of periodontitis is clinical attachment loss, which means that our perio charting and having a comprehensive perio chart, not just one that indicates that the patient has 5 millimeter probing depths, but one that demonstrates that these are clinical attachment loss areas, that there are in fact furcations or recession points, provides a more compelling data piece for our patients. Now, let's dive a little bit into gathering an appropriate diagnosis. Now, gathering a diagnosis does require us to take a step back and look at things like our patient's oral hygiene status, because we do know that indicators like the composition, location, duration, and presence of biofilm is going to be a critical driver. But unfortunately, for many providers, we have used the amount of debris as the beacon or benchmark for if we choose to do things like active periodontal treatment. And the reality is that while oral hygiene status and the presence of biofilm certainly is a piece or aspect of the puzzle, it is not the determining factor of how we diagnose our cases. It is important to know that while we do see patients who have periodontitis in a perio surgical suite, that staging a patient, stage 1, 2, 3, and 4 are not the only options we have available for our patients. So we can see patients in a state of health, as you can see here on the left. A healthy patient will have a stable periodontium, and the gingiva themselves will be healthy. We can have a patient like the middle here, where they do have a gingiva that is healthy, but the periodontium is reduced. You can see exposed root surface and subsequent recession. So these patients could be considered healthy. They are not periodontally active, but they do have that reduced periodontium. And finally, our gingivitis case. Now, gingivitis is considered a disease of the periodontium, but it is considered reversible. So there are gingivally diseased patients that we can in fact have in our chairs. And it's important to know that gingivitis, if reversed, is one of the best ways to control the subsequent movement into periodontal conditions. Once we see a patient who presents with periodontitis, now the AAP has outlined the stages and grades of disease. So here is the identifier for a stage 1 periodontally diseased case. you'll notice that the interdental clinical attachment loss is about 1 to 2 millimeters. And by that, I mean, and I apologize, this image is not my favorite, but we're looking at the earliest breakage of this attachment beyond the CEJ. So that's really what this image is intended to display, is the early breakage 1 to 2 millimeters beyond that CEJ. That is considered your stage 1 periodontal disease. And this is where you see that maximum probing depth of 4 millimeters. The assumption there is that you have that healthy probing depth of 1 to 3 millimeters, but you're probing 1, maybe 2 millimeters beyond the CEJ, which is what's giving you that depth. If the patient has bone loss, it will be mostly horizontal in nature. And again, as we've seen from our previous data here, bone loss will likely not be identified unless we see about 30 to 50% demineralization of the bone. So it will be nearly impossible for us to see bone loss in a stage 1 case. Stage 1 is considered the earliest stage of clinical attachment loss. And if we do not control the patient in stage 1, it's not a matter of if, it's a matter of when. The patient will likely progress into a stage 2. In a stage 2, now you can see that clinical interdental clinical attachment loss is about 3 to 4 millimeters. So we're probing 3 to 4 millimeters beyond the CEJ. And radiologically, now we are seeing radiologic bone loss that extends about 15 to 33%. So we're still in the coronal third. A lot of our periodontists are doing this now. So I'm going to kind of show you what they're doing. They're taking the root and they are splitting it into thirds, kind of like this. And then they're evaluating where is the crust of that bone. The crust of that bone is still in that coronal third. So that's where you see that radiologic bone loss there, indicating that the patient is still in that stage 2. Now, again, radiologic bone loss is just one indicator. Some of the other indicators that we could see is that maximum probing depth of 5 millimeters. And again, if we're going to see bone loss, it should likely be horizontal in nature. If we don't control the patient in stage 2, which, by the way, the AAP says this is our opportunity for clear intervention and subsequent monitoring. If we don't control it there, it's not a matter of if, it's a matter of when. The patient will move into stage 3. Now in stage 3, this is considered deep periodontal lesions that extend into the middle third of the root and beyond. So again, we are looking at splitting that root into thirds. I apologize for my drawing of my straight line there. But you can see that the crust of bone here is now extended into that middle portion of the root or beyond. So that's your stage 3. Interdental clinical attachment loss could be 5 millimeters. And a few important pieces to note as well. These patients could have furcation involvements of a class 2 or a class 3. These patients could also have vertical or angular defects. The concern as well now becomes tooth loss. And if the patient has lost any teeth due to perio, it will be 4 teeth or less. If the patient loses 5 or more teeth due to the periodontal disease process, that is the true indicator of a patient in a stage 4 situation. So again, in this stage 4 situation, the patient has now lost 5 or more teeth, so many teeth that now the patient needs to be put into a complex rehabilitation. Put simply, we suspect that there is going to be masticatory dysfunction, that we may have some serious occlusal trauma. Put simply, these patients are losing posterior molars that were important for masticatory function. And so now we're seeing single-rooted teeth performing the function of multi-rooted teeth, which can become a major challenge. Then we could see bite collapse. We could see flaring, mesial drifting, tipping, super eruption. I'm of the belief that your mandibular first molar is one of the most catastrophic teeth to lose early on. If you don't replace that, my goodness, the concern that we have, particularly when it comes to super eruption and then mesial drifting from those mandibular second molars, creates a major catastrophic issue, and then creates an issue where those teeth now with their parafunctional issues are at elevated risk for tooth loss as well. So this is the staging of disease. And if the patient falls into any of these categories, this, I think, is a critical identifier or indicator, for example, that these are patients where we need to be effectively monitoring them. And depending on the stage of the patient, the monitoring may involve simply non-invasive treatment like scaling and root planing, may also involve the integration of other kinds of modalities, integrating adjunctive services, etc. Once the patient is staged, which means we all agree the patient has active periodontal disease. If the patient does not have active periodontitis, you do not stage and grade them. So a healthy patient will not be staged and graded. A gingivitis patient will not be staged and graded. You stage and grade the patient once they present with periodontitis, and we all agree they have periodontitis. Again, looking back on the fact that interdental clinical attachment loss is a keystone benchmark for the identification of periodontal disease. So once you stage the patient, now we're going to grade the patient. And grading, for those of us who didn't learn about staging and grading in dental and dental hygiene school, this is going to be new for us, friends. Okay. Grading essentially allows us to look into a crystal ball and predict a few things. One, help us predict how fast, if we don't treat this disease today, how fast will it move? Some patients ask that, don't they? So is this like really serious? Do I need to like get this done today? They'll ask that, right? Hygienists, don't they ask that about crowns all the time? Doctor goes in, oh yeah, you got a broken tooth, it's fractured here, blah, blah, blah. You should probably have a full coverage crown done. Doctor leaves the room and the patient looks at us like, so is this really serious? Should I get this done today? And I think a lot of us think like, well, I don't think you're going to die tomorrow if you don't get your crown done, but your tooth is cracked. Yeah. The reason why the doctor brought it up and said this is a treatment that needs to get done is because, yes, this is a broken body part. That's what a tooth is. It's a body part. So your body part is broken and doctor is saying we need to repair this. So yeah, it is pretty serious. So if you're looking between, getting your crown done and, paying for your 18th subscription of a streaming service over the next year, maybe think about the fact that you've got a decaying broken body part in your mouth that is used multiple times a day when you're chewing food. But the other side of this is periodontal disease. And because periodontal disease is primarily chronic in nature, I think a lot of times we think, well, it's not really that big of a deal. You could probably wait a couple of months and see if we need SRP, or if you're busy this week and you don't need, you can't get it done this week. We could wait some time on it. And the reality is, grading gives us that prediction. If the patient is considered a grade C rapid rate, this is a patient who may have a tobacco habit, where that tobacco habit will, we know, increase the progression of the disease very quickly. If the patient is a diabetic with an A1C over 7%, if the patient has demonstrated in the past that the tiniest amount of bacteria will cause such an excessive destruction, or if, for example, the patient has an incredible amount of bone loss based on their age. So let's say the patient is, 40 years old and they have 50% bone loss, which is a lot given their age. We could theoretically predict this is a patient where we don't want to play the wait and see game. You have grade C rapid rate of disease, and that is extremely concerning. Conversely, we could have patients who are considered a slow rate or a grade A. These are patients who may be a non-smoker, they're a normoglycemic or a non-diabetic patient. These are patients that could have like tons of biofilm in the mouth. And Yet underneath all of it, there's very little destruction. When I see those patients, I always tell them, you won the genetic jackpot. Good for you, right? Because you've got tons of biofilm, and we should see a lot of disease, but in your case, we don't. So your immune system is really showing up in this case. That is awesome. This could be a patient, for example, who maybe is 90 years old. And that patient at 90 years old has, I don't know, 10% bone loss or something. So in these cases, this is a patient where we do predict based on their phenotype, their biotype, their immune system, their genetic makeup, all those important things, that this would be a slow rate patient where maybe perhaps we're not as concerned about progression for the moment. Now, there are other reasons why we would be concerned about a 90-year-old having uncontrolled inflammation in their mouth. So I don't mean to dismiss it. I'm simply using this as an identifier to kind of take a look at the percentage of bone loss based on their age. Then you've got the moderate, and most patients likely will fit into that moderate case. And most speakers who talk about staging and grading will say, start your patient in a B. And if you believe, you know what, this patient doesn't have enough identifiers to indicate that they're moderate progression, you move them down into a grade A. Or if the patient is a tobacco smoker, uncontrolled diabetic, etc., you would go ahead and graduate them into a C. The patient's grade will move with the patient. Let's say you have a patient who has an A1C of 8.4%, but then they controlled their A1C. They got on a good diet exercise plan and started taking their medications routinely and controlled their oral inflammation. And now their A1C is a 6.4. That patient could move from a grade C rapid rate down into a moderate. So it means that the patient's systemic health and their lifestyle choices could be a critical identifier for our patients. Okay, once we identify the disease process, once we say, okay, you have active periodontal disease and we need to do something about it, now we need to communicate with our patients and tell them you have disease and we need to move forward with treatment. All right, friends. So here comes the next step here in our games. We are going to play Family Feud. Now, for Family Feud, I'm going to ask you to log your answers into the chat box for this. And I'm going to take the answers kind of in order. And I think it's important as we take a look at them in this order. I'll be kind of walking along here. We all are family in dentistry, so we are not competing against each other right now. We are competing as dentistry family, the family of dentistry. So let's take a look here at Family Feud. 100 people were surveyed in a mall survey, and we asked 100 people, 100 patients, why do patients decline their periodontal treatment plans? Why is it that our patients would say, after we've talked to them about active periodontal disease, why specifically would these patients say, I understand what you're saying. I recognize that I need to, have treatment done, but I'm going to decline my treatment. All right. Top 5 answers are on the board. First option says money, cost, expenses. All right. Survey says, whoopsies. Sorry. I have to go ahead and turn off my, my indicator here. Sorry about that. All right. Whoopsies. Sorry about that, friends. I need to get my pointer here working. So let me just make sure that I have it on. Survey says cost or insurance. That was number 5, cost or insurance. Next one says it hurts. It hurts. Is that on the board? Hurts is not one of them. All right. We got lots of finances in here. All right. Insurance doesn't cover it. That's a good one there. They are skeptical. That's a good one. We're going to go ahead and go with they don't understand the risk of not undergoing treatment. So they're kind of skeptical. I don't know. A couple of other ones here. Phobia. Phobia is one. Is phobia on there? Sorry, that one's not one of them. Mistrust. Number one answer. Very good. Mistrust. Lack of trust in the dental healthcare professional is number one. Time. Sorry. Time is not one of them. Let's take a look at the other two answers that are on the board. Number three is the patient didn't understand the treatment. And option number four, the fourth most popular answer, is the patient didn't even understand their diagnosis. So yes, we do know how important patient communication is. And I love this. This is a resource from my friends at Perio Protect, talking about how important it is to share with our patients the fact that what we're doing is we're treating a bacterial infection. We're going to talk about Perio Tray therapy in just a short second. But it is important to recognize that when we're talking to our patients, when we're communicating with them, that we demonstrate how serious this disease process is. And the fact that what we're trying to do is reach an area that they likely cannot reach at home. So this is an amazing resource that our friends at Perio Protect have built and designed that helps us to, I think, better communicate with the patient. It starts with, I'm concerned. I'm concerned about your bleeding score. Currently, 65% of your mouth is bleeding. The ideal score for bleeding is under 10%. I know you're trying hard at home with toothbrushing and flossing. The challenge is toothbrushing and flossing cannot reach the deep areas where the disease is. That's why we are prescribing, let's insert that treatment. Under the gum tissue scaling and root planing, Perio Tray therapy, probiotics, mouth rinses. Not only will you have an improvement in your gum health, you will also have an improvement in your systemic health, just as an example. So these are some really great ways, I think, to kind of change the narrative for our patients and help position our communication in a way that helps our patients to accept treatment. Okay, so we've assessed the patient, we have diagnosed the patient, we have planned the patient, and now we need to implement. So now we're going to play a game of Survivor. In this game of Survivor, I'm going to be watching in the chat box here. In this game of Survivor, you are on a deserted island, and I want to know, in this deserted island, what scaler do you want to pull out of your back pocket in order to address calculus? So I'm going to be showing you various pieces of calculus, and I want to know what instrument would you likely use to remove it. Let's begin by looking at this giant piece of calculus across the buccal aspect of number 14, which looks super erupted, which means we already know that this particular patient is going to have concavities where we need to be articulating into various areas. So you're on a deserted island and you've got to survive with a piece of equipment or a hand instrument to help you remove or debride this piece of calculus right on the direct buccal of number 14. So we've got a couple of options here. I've got some piezos. I've got some cavitrons. Ooh, I've got a 1516. So that's a Gracie 1516. I've got a curette here, 910, a triple bend in the ultrasonic. Yep. I hear ya. Well, let me tell you what I, as a periodontal hygienist, would want in my back pocket on Survivor Island. This is the Queen of Hearts. This, to me, is the game changer when it comes not only to removing a large spicule of calculus, as we just saw there, but also being able to actually articulate into that furcation area. I've got the QR code here, so if you all are interested in learning more about the Queen of Hearts, check it out. This is shaped kind of like a McCall's. So it's got a bend in it just like this. And it's got a double-sided rounded toe. So we've got some beautiful opportunities here for debridement. 6 inches of cutting edge. I'm sorry, 6 millimeters. Can you imagine 6 inches? 6 millimeters of cutting edge in this particular instrument. So provides an incredible opportunity for us to be able to reach into those furcations and into those difficult to reach root concavity sites. All right, we're back on Survivor Island. Take a look, folks. We've got lower anterior calculus. Take a look here. We've got lower anterior calculus. We've got some crowding in some of these areas. We've got interproximal calculus here. You are on Survivor Island. What instrument are you going to use to debride this calculus? All right, we've got a 204S. That's a good one. I like a good old 204S. 204S is has a nice kind of bend in the shank, and it's a sickle Cavitron triple bend. Very nice. Cavitron triple bend. And I think the triple bend does a beautiful job in getting into a lot of these areas. These interproximal crowded spaces, we might need something a little bit more. But yes, I absolutely agree. Our ultrasonics do a beautiful job. Triple bends, I love that. So if we take a look at the architecture and the anatomy here, again, we know, and I'm going to say something really provocative because I am a dental hygienist in the state of Arizona that just passed OPAs, giving dental assistants the opportunity to scale prophies. So one of the dynamic differences we recognize in performing supragingival scaling and performing more advanced treatment for our patients is being able to integrate or use advanced instrumentation techniques to articulate into these difficult to reach areas. This is what we spend so much time in dental hygiene school studying. The Bogey 513, who doesn't love a good Dr. Emily Bogey instrument? I love it. This is my favorite. The Morse 0-00. Take a look at this thing. If y'all have not tried it, it is yummy. And here's the QR code for you to try it. This is an ultra narrow, tiny blade. And it's a double-sided, double-ended blade. I absolutely love this. Oh my goodness, best instrument ever. Yeah, you're so spot on. It is the best. This thing will get into anything that is crowded far better than literally anything I've ever held in my hand. So this is the Morse 0-00. This is a gorgeous interdental instrument. And again, QR code there for you to check it out. This is from our friends at PDT. Absolutely love it. Take a look at how tiny this thing is. And it's got a little bit of a curve to it. So it helps us to get directly in underneath that contact. If you have not tried it, you will be obsessed. You will need it in every kit. I am telling you this right now. It is the best. All right, last one on Survivor Island. You've got a patient with this all on X, and the patient has a little bit of exposure here, but we have to be able to get to all of those areas. Ooh. What are you going to use in order to treat this patient? You're on Survivor Island. You've only got one thing in your kit now. What can you use to be able to debride this? Jess, I hear you. Air polisher. Kristen, air polisher. Air polishers are awesome, aren't they? They really are, to be able to get in there. As long as you've got an air polisher that allows you to both use supra and sub so that you're not just loading that sodium bicarbonate. Sodium bicarbonate will damage that implant oxide layer. So you want to make sure that you have the right kind of system in there to be able to reach in there. I don't know about you, but when I have my patients come in with an all on X, it is a challenge to be able to reach into those areas. No question about it. Oh, the Wingrove implant system. Bobby, you are spot on. Yes, the Wingrove, something like that. I completely agree. I'm a huge fan of the Wingrove series, but even more so, I am a huge fan of the Pinheiro. So this QR code will take you to the Pinheiro set, invented by Dr. Pinheiro. These are instruments that are actually shaped precisely like an implant. So here he is showing my bestie Amber Auger what the Pinheiro set is, and being able to allow these instruments to come in and kind of retract. Here is the TI1. So the TI1 is really designed for anteriors. As you can see, it's got a scoop appearance to it to be able to go into the direct buccal and the direct lingual. This is the Pinheiro arch set from our friends at PDT. So again, it allows you to be able to direct there. We're going to take a look at the Perio 2. The Perio 2 is designed for those posterior areas, and specifically that Perio 2 is made for us to be able to perform scalings onto the mesial aspect. Here's the Perio Arch 3. These are mesial and distal areas. So now you're able to get into those hard to reach distal sites with that Perio 3. And then you're going to see the Perio 4. The Perio 4 is shaped kind of like a sickle, and it's designed to be able to get in underneath that bar or in between the tissue and the prosthetic device itself. So you've got inside of this Perio kit 4 scalers or 4 pieces of equipment, titanium based, that allow you to be able to retract some of that tissue or distend that tissue without creating trauma and being able to effectively debride the area, which I absolutely love. All right, so we just survived the island, and now we are moving on to the Newlywed Game. For those of you who remember the Newlywed Game, this was a game where newlyweds sat down and had to guess important things about each other, and it really adjudicated their ability to understand each other. As someone who just asked my husband yesterday to go to Chipotle and order my Chipotle bowl, I quizzed him on, do you know what my Chipotle order is? Don't worry, he passed. He knew it. So we know how important it is to feel known or understood. Yes, I see that, Dale. Yes, you did get it right. You did miss my Coke, though. Anyway, so the Newlywed Game really helped us to understand how well newlyweds knew each other. In this realm, I'm going to ask you to share how well do you know your patients. So I'm going to watch in the chat box here. I want you to tell me how well you know your patients. What do your patients want in a mouth rinse? When your patients are being prescribed a mouth rinse or talking about the things that they like in a mouth rinse, what do your patients want in a mouth rinse? And I'll tell you, patients can have different diverse requests or needs when it comes to a mouth rinse. Kristen says here, fresh breath. Absolutely. Jindy says fresh breath. Yes. Antibacterial. Ooh, non-alcohol, non-burning. They don't want it to hurt them. You are absolutely spot on. Sounds to me like your patients are just like mine, in that your patients and my patients want to have good antibacterial benefits. They want to have fresh breath. They don't want it to burn, and they don't want it to have that stinging sensation of alcohol. And yes, in many cases, they do want help with dry mouth. If your patients are anything like mine, they have fallen in love. See what I did there? Because we're playing the Newlywed Game. They have fallen in love with Closest Mouth Rinse, which actually is a rinse that is everything. Just like my husband is my everything. This is everything for a patient. It is non-alcoholic. It is non-burning. It helps with dry mouth. It does a beautiful, it's actually designed for patients with oral mucositis following cancer treatment. It is antibacterial, and Closest Mouth Rinse has an active ingredient in it called chlorine dioxide, which actually kills volatile sulfur compounds, or VSCs. Those are the compounds that are responsible for causing bad breath. So this is kind of the catch-all. It is the perfect Prince Charming for your patients in being able to help them. And yes, Kristen, with patients with burning mouth syndrome, because this is non-irritating, and particularly, Kristen, you'll want to give your patients the unflavored version. Sometimes a mint can actually irritate some of that burning sensation. This is a beautiful medicament. Not only that, but we have seen that a complete Closest oral health system does a beautiful job of being able to reduce perio probing depths and subsequently bleeding sites. So again, we love that antimicrobial benefit. Okay. Another question on the Newlywed Game. How well do you know your patients? Do your patients enjoy meticulous home care? Tell me, do they enjoy us telling them to brush for a full 2 minutes, at least twice a day? Do our patients love it when we give them floss? We use the F word and we say, you need to make sure that you're addressing or flossing in between the teeth. Do your patients enjoy or appreciate it when we give them 18 different kinds of brushes and we say, use this one in this area, use this one in this area, try this over here. Oh, you can't shove your entire hand in your mouth? Well, my goodness, let's try this, let's try that. Do your patients enjoy meticulous home care? I am seeing Elisa says, yes, I love that. I love that your patients enjoy meticulous home care. The rest of you, it sounds like your patients are just like mine. Generally, no, they do not enjoy meticulous home care. And that's where my patients have fallen in love with a new way to provide appropriate home care. So these are oral probiotics from our friends at BioGaia. I'd love to see in the chat box, how many of you are using Periodontists by BioGaia with your patients? These are exactly what you think they are, probiotics or health producing bacteria. And these are lozenges that we can give our patients. These lozenges reintroduce healthy bacteria into the mouth, which is amazing. It allows us the opportunity to let healthy bacteria recolonize the mouth. And it turns out when you recolonize the mouth, we see a dynamic drop in bacteria like Prevotella intermedia, Porphyromonas gingivalis, and good old Aggregatibacter actinomycetum comitans. Rachel, your question, how soon can I see the result? Literally within 14 days. Here's a patient who had overt gingivitis, and this patient, as you can see, has an incredible bleeding tendency here. This particular patient did not have oral hygiene instruction delivered to them. The only thing that they received were these Periodontists lozenges. And after 14 days, gingival index fell, about an 85% reduction in bleeding. So within about 2 weeks, you will absolutely see a dynamic shift. Now, 2 weeks is on the longer side. Most of your patients, if they are meticulously utilizing this product, we'll certainly see a much faster turnaround. And why is that? It's because these bacteria actually colonize the saliva and they colonize our oral microbiome. They actually compete with plaque for adherence onto the teeth. So not only do we see a reduction in bleeding scores, we also see a reduction in plaque scores. How long do they have to use it? Great question. My patients who are diseased will use 2 lozenges a day. Once the patient gets down into a state of health, they will use 1 lozenge a day, and that's the maintenance. And the question is, how long do they have to use it? Well, the same as how long do patients need to plan to brush their teeth? Well, every day, right? We like to tell our patients every day. If they don't brush their teeth every day, ideally twice a day, if they don't brush every day, the bacteria is just going to recolonize. And the same is true of these probiotics. So they need to use this long term because this is an oral hygiene solution. Again, this is Periodontists from our friends at BioGaia. Your patients can actually order this subscribe and save on Amazon Prime, which is awesome. And it turns out BioGaia is now in CVS stores across the United States, which is really amazing. All right, everybody, get your phones out. We are going to move on to another fabulous Kahoot. So let's go ahead and get your phones ready. I'm going to go ahead and pull up a QR code here so that we can have some fun and learn a little bit about what you know about Perio Tray therapy. This is going to be real great. So I'm going to go ahead and expand to this QR code. Again, you'll go ahead and scan this with your phone. So that you are able to join in on the fun. I want to see what you know about Perio Tray therapy. And I think we have a fabulous opportunity to kind of collaborate on some potential adjunct therapies that we can use for our patients. So I'm super excited about this. I want to learn what you know and really kind of deep dive into, in my opinion, some of the provocative things that have to do with the management of periodontal disease. You know, we're kind of stepping into this mode of considering maybe not as invasively treating disease and maybe giving our patients an opportunity to more non-invasively treat their disease. And so we're going to talk about some of those key modalities together, which I'm super excited about. So buckle up, buttercups. We've got a fun Kahoot ahead here. And I know you all are going to have a really great time with this one. So again, that QR code is there. We'll give it another few seconds, and then we're going to go ahead and get started in taking a look at what we know about Perio Tray therapy. Let's get started, friends. Here we go. Are you smarter than a periodontist? Let's learn about Perio Tray therapy. And I want to know what you know. First question is a poll question. What do you know about Perio Tray therapy? This is the first time I'm hearing about it. I've heard of it, but I don't think it works, so I haven't used it. I've heard of it, but we just aren't using it in my office, or we use it in my office. I'd love to hear from you about what you know. What is your current working knowledge of Perio Tray therapy? Just to kind of get the ball rolling here. Okay, I have heard of it, but we just aren't using it in my office. Okay, let's see if we can change that today, folks, because one of the things that may make our periodontists smarter than us is that they will pull out the evidence-based data and the evidence-based products that they know will help support their patients' healing. So stay tuned, friends. All right, quiz. What is the primary benefit of using Perio Protect to treat periodontal disease? What do you know about this? What is the primary benefit? It requires invasive surgery. It eliminates the need for a dental cleaning. It provides a non-invasive alternative to periodontal surgery, or it only treats gingivitis, not periodontal disease. What is the primary benefit of recommending or prescribing Perio Protect for your patients? That is right. It provides a non-invasive alternative. So how many of your patients, number one, don't want to go and have perio surgery done? Number two, are on a long waiting list to get perio surgery done? Number three, don't want to be referred at all and are wanting to try other efforts to be able to treat their periodontal condition, where Perio Tray therapy may be a terrific option. Jess in the lead, you Einstein. Number three, which of the following best describes how Perio Protect works to treat periodontal disease and gingivitis? Which is the best? It relies solely on antibiotics to reduce infection. It uses custom trays to deliver medicaments directly to affected areas. It removes the need for regular brushing and flossing. It replaces the need for professional dental visits. So which best describes how Perio Protect works to treat periodontal disease and gingivitis? That's right. It does use custom medicaments and these trays. It does not require antibiotic usage. And we never say, hey, this is going to replace brushing and flossing or replaces the need for a dental visit. Dr. Dre in the lead. I love it. Question number 4. How does Perio Protect compare to traditional perio surgery in terms of effectiveness for peri-implant disease? It is less effective than surgery and it cannot treat perio-implant disease. It can treat peri-implant disease almost as effectively, but non-invasively. It only works for gingivitis. It has no effect on peri-implant disease. Or it is effective only for soft tissue disease, not for peri-implant disease. That's right. It can treat peri-implant disease almost as efficiently, but it is non-invasive versus some of the flap procedures that most of us are doing in perio offices across the United States. Just back in the lead. And the last one, why do most periodontists express hesitation toward using Perio Protect as a treatment option? Why do most periodontists have a hesitation? I don't know if you've heard of this. They believe it is less effective than traditional surgical methods. They are concerned about the long treatment times required. They believe it's too expensive for patients to afford, or they feel it doesn't address the causes of periodontal disease like surgery does. Why is it? Interestingly enough, the vast majority of periodontists think that it's not as effective as traditional surgical methods. Stay tuned as we look at the data. However, periodontists alike agree that it doesn't require a long time for treatment. And in fact, they don't even think it's too expensive for the patients to afford. And periodontists do agree that Perio Protect treatment does help to address a lot of the underlying conditions. It does, in fact, target bacteria and open periodontal wounds. They agree with this. They, however, believe that it is less effective than surgery. All right. In third place, we have Z. I love is that a Green Bay Packer helmet? In second place, Josh. I love it. We changed into the mustache. I like it. And in first place, Jess. Fabulous. Congratulations, folks. Very nice job. Just absolutely wonderful. And thank you so much for joining me for that wonderful and compelling game. So let's dive into the true heart of it. Why do periodontists hate why are they opposed to Perio Protect? Here's the thing. A lot of them actually aren't against Perio Protect. This is a case from Dr. Gordon Fraser, who is a periodontist. And he, like many of his colleagues, say, as a periodontist, I've tried just about every method of treating periodontal disease that makes scientific sense. The key to success, Dr. Gordon says, is long-term maintenance. And Perio Protect is the one treatment that I have utilized in the last 5 years that works. Perio Protect is easy for patients to use, which means high compliance, and high compliance means lots of success. It has become part of my winning formula. So it's not all periodontists. In fact, a significant portion of our periodontists are smart. They look at the data and they recognize that they will get optimal healing when they co-therapeutically use Perio Protect alongside their therapies. What is Perio Protect? Perio Protect or Perio Tray therapy is a non-invasive treatment for treating periodontal disease. And by periodontal disease, I mean gingivitis, periodontitis, and implant disease. It utilizes custom-made trays that deliver a medicated solution deep underneath that gingival margin. So these custom trays are filled with 1.7% hydrogen peroxide gel. That hydrogen peroxide gel creates an oxygen-dense environment, which not only kills anaerobic bacteria, but creates a healthy wound healing medicament system that allows us to treat that diseased sulcular epithelium. When patients receive Perio Tray therapy, not only do they notice significant improvements in their gingival health, reduction in probing depths, decreased bleeding, and diminished inflammation, they also report fresher breath and whiter teeth, which is absolutely amazing. The clinical data alone really points to or indicates an extremely effective modality, particularly when we look at comparison of traditional surgical treatment for periodontal disease. So when you compare Perio Protect to Perio treatment alone, it turns out that combining Perio Protect treatment with Perio treatment is going to give you statistically significant benefits. And in randomized controlled trials that have looked at comparative analyses, combining Perio Tray therapy with things like root planing create a synergistic effect where we see significant decreases in perio probing depth numbers and optimal improvement. Now, what is the ideal protocol for a Perio Protect case? Well, early on, I gave you the course resource. And Angela, if you don't mind, friend, tossing that into the chat box again, the resource that we are providing to you is a customized protocol developed by Dr. Sam Lau, a periodontist, designed to help practices to build what kind of a protocol they want to integrate into their practices. And inside of his protocol, he has listed out how should you integrate the use of Perio Protect. Now, typical Perio Protect protocol actually begins before you treat the patient. And this goes back to wound healing or wound treatment modalities. Put simply, Perio Protect protocols are aligning with what our medical colleagues are saying we should be using in order to treat wounds. My sister's a foot and ankle surgeon. I hope you all will consider joining me and Dr. Sanders in Milwaukee this summer to talk about how she treats foot wounds. Before my sister goes in and does any therapy, she pre-treats that wound with medicaments to help reduce the bioburden. And so this wound therapy protocol follows that same piece. That you would essentially, at a recare appointment, perio chart the patient, identify they have periodontal disease. Hygienists, should you start a prophy that day? Please say no, please say no, please say no. If the patient has perio, you should stop right there. Scan the patient and get that patient ready to start Perio Tray therapy. So this allows you the opportunity to scan the patient. You send those scans off to the Perio Protect lab, and those trays can either be sent directly to the patient to start using or in office for you to dispense to the patient when they come back in to start their treatment. These tubes are loaded with a 1.7% hydrogen peroxide gel. They should be worn for 10 to ideally 15 minutes a day. And when the patient is in active treatment, you want them wearing these for anywhere between 2 to 3 times a day. Most patients, like my husband, like to wear them in the shower. On a super side note, HIPAA, my husband has he is my patient too. He has perfect gingiva, which is why I married him. But he wears Perio Trays from Perio Protect because he likes having whiter teeth and fresher breath. So it is really terrific. Josh asks, would you recommend a debridement before trays? You could, but not necessarily. One of the benefits to starting with trays first is that the hydrogen peroxide actually breaks down the protein matrix of calculus. So it's going to soften that calculus first, and it helps to begin early wound debridement. So think about your cardiovascularly diseased patients. What are we concerned about in cardiovascular diseased cases? We're concerned about bacteria entering the bloodstream at that point of that subgingival space, right? And so sometimes we will even pre-med our patients because we're scared about how much bacteria is going to dump into the bloodstream. I don't mean to say that you wouldn't pre-med a cardio patient. I don't mean to say that. But what I do mean to say is we're finding that pre-treating the patient for about a week or two before you, with Perio Protect trays, before you perform the debridement, really helps to strengthen that oral mucosa so that you're not going to get as much tissue trauma. You're not going to get as many tissue tags. We should see a reduction in the bioburden or the amount of bacteria that's entering the bloodstream and creating a bacteremia. You're going to see your patients respond more favorably to treatment. And again, that calculus is going to soften nicely. So ideally, about 2 weeks before you would debride, you would start this patient on trays. And again, think about that workflow in your hygiene appointment. Patient comes in for their prophy. They sit down, they're ready to go. You take x-rays, you probe them. You're about 25, 30 minutes into the appointment and you're going, oh no, we need to start perio treatment. And respectfully, hygienists, I do not think that we should be performing a prophy at that time, nor do I think that we should even try to squeeze in a quad just to get something done. Scan the patient, get them set up with these custom trays. And if your patients are anything like mine, although they might be concerned about periodontal disease, all they really want to talk about is whitening. So this for me becomes a way for me to partner with my patients and say, hey, I'm concerned about your periodontal condition. I know you want to talk about whitening. This is a treatment that will actually allow both of us to achieve our goals. If you use this product routinely the way you should, we will see a reduction in bleeding, a gingival index. We will see an improvement in perio probing scores. Your outcomes following perio treatment will be better, and you will get fresher breath and whiter teeth. So this really provides a win-win solution for our patients. It seems like most of you have heard of the product, and yet many of us are not integrating it into our practice. So I've got a QR code down the way that if you are interested in integrating this into your practice, scan that QR code. It will take you to my custom page where I've asked the Perio Protect team to load things like a calculator to estimate, hey, if we recommended this for all of our SRP cases and we charged X amount, how much more production would we bring in by doing this? Now, we know that it's not all about production, but this is an important step in the process. If we're going to be integrating or changing our protocols, we need to see production and optimal patient outcomes following, if that makes sense.
Hi, I'm Dr. Timothy Donnelly. I'm a periodontist out of Bowling Green, Kentucky, and this is Are You Smarter Than a Periodontist?
All right, that is my bestie, Dr. Tim Donnelly. He is going to help us to identify, are we in fact smarter than a periodontist when it comes to these cases? So I'm going to be watching in the chat box here, friends. This is Kayla. Kayla is 26 years old. She has a history of congenitally missing laterals. She has a non-contributory medical history. She also has no medications, no known drug allergies, and her vitals, she was a little hypotensive today. On the radiographs, she has no radiographic bone loss and she has no radiographic calculus. She has a 65% bleeding tendency and her probe depths are 3 to 4 millimeters. Based on what you're seeing here with Kayla, what would be her perio diagnosis? Just based on what you're seeing here in this case. She has a 65% bleeding tendency, probing depths of 3 to 4 millimeters, no bone loss visually noted on radiographs, no radiographic calculus. Let's fill up that chat box with what do you think her diagnosis is? We've got a couple of inserts here, gingivitis, grade 1 or stage 1, generalized gingivitis. All right, let's take a look.
The American Academy of Periodontology states that if we're able to diagnose patients earlier, deliver earlier intervention, and actively monitor susceptible patients, we can not only reduce costs associated with managing disease, but we also have a better opportunity to control disease, as shallow lesions make it easier to perform mechanical biofilm removal or deliver pharmacological agents.
This particular patient is considered a gingivitis case. So when Dr. Donnelly had shared about how important it is for us to treat these more shallow cases, based on the fact that we don't have any concerns of clinical attachment loss in Kayla's case, but we have those 4 millimeter probing depths indicating a gingival enlargement, this provides us with the opportunity to effectively address this patient. All right, let's take a look at Anthony. Anthony is 43 years old. He has a family history of cardiovascular disease. He does have a tobacco habit. He smokes 5 cigarettes a day. He is on no medications, no known drug allergies. He is hypertensive. He does have some changes radiologically in bony contour observed radiologically. So some changes we can see there. He has a 32% bleeding tendency, probing depths of 3 to 5 millimeters. Probing depths of 3 to 5 millimeters. So let's get our guesses in here. Stage 1 grade B, stage 2 grade B. All right, we're getting some answers in here. So I think we're using that tobacco habit as the identifier for that grade B. We're just looking at now what stage is the patient, stage 1 or stage 2. Let's see what Dr. Donnelly has to say.
The American Academy of Periodontology reminds us that for patients in stage 2, management remains relatively simple for most cases, especially if we can apply standard treatment principles, including regular personal and professional bacterial removal and monitoring to arrest disease progression. However, they do also remind us that observing patient response to standard treatment is a critical component to guide how we manage treatment. In fact, they remind us that patient response and the grade of the case can guide the need for more intensive management in specific patient situations.
All right, so this is a stage 2 grade B case. And as Dr. Donnelly pointed out, if that grade is a grade B, the tobacco habit may require us to consider other advanced modalities in this case. Let's take a look here at Paula. Paula is 65 years old. I think my medication is making my gums swell. She has cardiovascular disease. She is on amlodipine for hypertension. She has COPD. She's taking Spiriva. She has a history of tobacco use. She's been smoking for 50 years, a pack to a pack and a half a day. And she has a family history of diabetes. Dad had diabetes. So I want you to already think about this case a little bit, some of the nuances of her medical conditions. As we take a look at her radiographs, the following teeth indicated teeth that were hopeless prognosis and were subsequently treatment planned for extraction based on the overt levels of periodontal disease. So as you can see here, our periodontist identified that teeth numbers 2, 3, 4, 15, and 19 should all be extracted due to the sequelae of periodontitis. So now the question becomes, what is the diagnosis for this patient, Paula? I'm seeing some stage 3 grade C's. I'm seeing some stage 4 grade C's. let's take a look at what our periodontist has to say.
The American Academy of Periodontology reminds us that when we lose control of our patient's periodontal conditions, there's an increased risk of loss of dentition, which then requires complex rehabilitation to achieve stabilization and restoration of masticatory function.
So this is a patient who has lost so many teeth. Remember, this patient is now losing 5 teeth due to the sequelae of periodontal disease. So in this scenario, this is a patient who would be considered a stage 4, grade C case. And the identifier for the patient being a grade C is her tobacco habit. All right. Let's figure out, are we really smarter than a periodontist? All right. So we're going to take a look at some cases, and I'm going to ask you via Kahoot to share what your insights or thoughts are on these cases. All right, meet Julie. Julie is 36 years old. She has a non-contributory medical history. Last physical was 4 months ago. No medications, no known drug allergies. She does report that her gums bleed when she brushes her teeth. Here are the photos of Julie's case. So take a quick look here. This was after she was probed. After she was probed. Let's take a look at her radiographs. And right away, as we take a look at those radiographs, a few things that I'm looking at as a periodontal hygienist. Take a look at that bone level around 2 and 3. Take a look at that change on the mesial of 5. That's an area of concern for me. Take a look here. We're seeing a little bit of a dip here in the bone on the mesial of 29. We might, I don't know if this is a superimposed foramen or if that is resorption. We see a lot of resorption in perio. Take a look at how scooped we are here with that bone level, right on that facial of 22. So we've got some changes in the bone there. Let's take a look at our perio charting in this case. So we've got pockets of 6s and 7s. We've got some bleeding. Got a 9 here on the distal of 6. Got some bleeding sites here. Notice the free gingival margin where we have some gingival enlargement in other areas. We've got 1, 2, 1 for recessions. Notice in the aqua blue here, you have furcations of 1 millimeter, or of a class 1 and a class 2 here on the distal of 15. Corey, I love where you're going with this. Is occlusal trauma contributing to this case? Yeah, take a look at that. Take a look at that. Yeah, I believe this is a contributory factor. All right, friends, let's get your phones out. We are going to go ahead and take a quick peek at what you all think specifically about this case. So get your phones out. We are doing a fun and fabulous Kahoot here. I'm going to go ahead and expand that so we can all take a look at this. This is looking at our patient case, Julie. So we want to make sure that we are logging in here. You guys are experts on this whole Kahoot thing. I am just loving this case. You guys are so great. So again, you're going to go ahead and scan that QR code. It is going to bring you into the game, which is so fun. Lets you participate, share your smarts. The questions that we're going to be asking in this Kahoot are directly related to this particular patient's case. So we're talking about Julie. Again, Julie is 26 or 36 years old. Last physical exam 4 months ago, nothing on the health history, and no medications, no known drug allergies. Radiologically, we did see radiologic changes. She had probing depths of 5, 6, 7 localized, 8s and 9s. So we're going to be diving specifically into her case. All right, let's get started. And I want to learn from you a little bit about this particular case. All right. So the first ask is a quiz question. What is the number one key indicator that this case is currently active? What points to the fact that this patient is active? Is it bleeding tendency? Is it furcation involvements? Is it mobility? Or is it clinical attachment loss? What is the number one key indicator that this particular case is currently active? And bleeding tendency, for those of you who said bleeding tendency, you would be correct. So we can see clinical attachment loss, but as we discussed earlier, we can see clinical attachment loss in an otherwise stable patient. Think about your perio patients who had SRP, responded well, came out the other side. So now they're in a maintenance where they do have clinical attachment loss, but it's in a state of stability. So clinical attachment alone does not necessarily mean that they are active. But that bleeding tendency, you betcha, spot on, Jess in the lead. Absolutely. Okay, this is a poll question. What would be your first action in addressing this patient's case? Immediate referral to perio? Begin with SRP, then refer if the patient has non-responsive areas? Begin with SRP, but include Perio Protect to improve outcomes? Begin with SRP, but include probiotics to improve outcomes. What would be your ideal mode of choice in this particular case? Okay, the vast majority of you said begin with SRP, but include Perio Protect to improve outcomes. Now, I would agree. Most perio offices are going to say you should probably start with SRP and then refer over what's not going to respond. But we all know that when the patient has 6s and 7s and 8s and 9s, that their care is going to be compromised. So I do agree in this particular scenario that Perio Protect would be a terrific way to help support our patients. Okay, question number 3. Julie says she just wants her free cleaning her insurance covers instead. How would you in your office proceed with this case? Perform the prophy with an informed refusal signature. Perform the prophy and encourage a shorter recare system. Refer to Perio for a second opinion. Refuse the prophy and give the patient a referral elsewhere. This is a tricky one. So I want to know, in your practice, how would you respond to this particular type of a patient? Refer to Perio for a second opinion. Yeah. And we love it in Perio, getting we call them PITA patients, pain in the you-know-what patients, who are ready to argue with that. But thank you for referring them over to Perio and allowing us to support that second opinion. All right. Quiz question. What is Julie's stage of periodontitis? How would you stage her? Is she a stage 1, a stage 2, a stage 3, or a stage 4? Based on the identifiers that we saw in Julie's case, which would you select for her? Stage 1, stage 2, stage 3, or stage 4? Okay. One of you said stage 2. The vast majority of you said stage 3. A few of you said stage 4. All right. Well, let's take a gander and let's see what Dr. Donnelly has to say.
Let's take a look at the entirety of how the patient is presenting. Here, we are observing generalized 4 to 7 millimeter periodontal pocket depths, sites of class 1 and 2 furcation involvements, and the radiographs demonstrate moderate ridge defects. This classifies the patient as active periodontitis stage. Let's take a look at the entirety
Sorry about that.
of how the patient...
Stage 3 periodontitis. So this is a terrific example of a patient where we haven't necessarily identified that the patient will be losing teeth yet. So it's too early to call this patient a stage 4. However, in this particular scenario, this absolutely is a patient where we are concerned about those advanced probing depths and those moderate ridge defects. Let's look at another example patient case. This is Kyle. Kyle, isn't he cute? Look at that smile. Kyle is 30 years old. He is a type 1 diabetic. At his last physical 2 months ago, he had some assessments captured. His A1C was an 8.4%. He is on insulin and he has a family history of diabetes. Both mom and brother have diabetes. And his chief complaint is tender gums. Okay. So again, Kyle, type 1 diabetic, last physical 2 months ago, indicates an A1C of 8.4%. He is an insulin dependent diabetic with a family history, both mother and brother. All right. So let's take a look. Again, get your phones out, friends. And we are going to ask a couple of questions here as it relates to our bestie Kyle here. So again, go ahead and scan that QR code. It should bring you directly in to be able to access that Kahoot. Again, we are talking about 30-year-old Kyle. So he's 30. He is a type 1 diabetic. Last physical exam 2 months ago, A1C of 8.4%. He complains of having tender gums, and he's got a family history of diabetes. Both mom and brother are diabetics. So this is a patient that I think we need to keep our eyeballs on, particularly if this is a patient who has tender gum tissues already, where we should be concerned about potential of, periodontal condition in this particular case. All right, let's take a look. We're going to ask you about our bestie here, Kyle, the 30-year-old type 1 diabetic with an A1C of 8.4. So, quiz question number 1. What is Kyle's grade of periodontitis in this case? Grade A, grade B, grade C, or no grade? The case isn't active. What is Kyle's grade of periodontitis in this case? So the answer is grade C. Why is it a grade C? Because his A1C is an 8.4%. So remember that diabetic cutoff for the grades is at a 7% under. That patient is a grade B. 7% or over is a grade C. So because his A1C is 8.4, he would be considered a grade C. Very nice. All right. Jess is in the lead. We've got our founding father's wig on. I love it. All right. So what additional measures do you consider or include when you have a diabetic patient? You can go ahead and type it in. You got about 30 seconds. What other things would you do for a diabetic patient? That patient has diabetes. You know that they're going to be compromised in their healing. What are some of the things that you would do to help a patient like that? So type in your answer and submit. Got about 11 seconds left. I'd love to see what kinds of things do you do in your office that allow you to treat diabetics in a unique way. Oral hygiene instruction, Perio Protect, and water pick. So I agree, oral hygiene instruction. I guess I would want to know, are there different things that you would do for a diabetic patient versus a non-diabetic patient? Water pick, I completely agree. I'm a huge fan of the water pick myself as a perio hygienist. And Perio Protect is a really terrific answer. Stay tuned as we talk about the ways that Perio Protect have actually helped improve our diabetic cases. Question 3, according to the AAP, an A1C of blank demonstrates optimal outcomes during periodontal treatment. Now this is A, 6.5% or under, B, under 7%, C, 7.5 or below, D, both A and B. According to the AAP, once we can get the patient at what A1C would we see optimal outcomes? So it's both A and B. Technically, if we can get their A1C under 7%, that's where we know they will respond favorably to treatment. Anything over 7%, this is where we really run into concerns. So I think this really provides us with the opportunity to kind of dive into what things can we do to help support our patients in controlling their A1C. And I love that one of you suggested the use of Perio Protect tray therapy for your diabetic cases. So this is a QR code that I had promised you that will take you to the Perio Protect site, where you can learn more about Perio Protect. You can utilize that productivity calculator. It also has information, a lot of scientific data on there, because we know anytime that we integrate a treatment or therapy in our office, that it has to be evidence-backed. And so there's some amazing data out there that demonstrate that our ability to use Perio trays. Now, we've talked about using Perio trays initially before we do mechanical intervention, before we do a debridement, advocates for chronic wound care. And that kind of aligns with the American Medical Association's wound healing component, where they say if you can manage the cause of the disease before mechanical debridement, that you can help to reduce inflammation dynamically. And for those of you who have seen my programs, particularly when it comes to deep diving into diabetes, you know that this is like my favorite case in the whole wide world to present. So this is a patient case. This patient came in, they're diabetic. They have a previous history of MI. When they came in, this is kind of what they looked like here. They demonstrated major overt concerns associated with the patient presenting with oral inflammatory conditions and calculus. This particular patient not only had a history of MI, so they're a cardiovascular risk, but they also had an A1C of 9.3%. This patient did not receive mechanical treatment. They did not receive scaling. The only treatment they received was for 2 months, they weared their Perio Protect tray therapy. The patient came back in 2 months later. And by the way, the post-op that you can see here is after tray therapy. So no debridement had been done, but you can see how the calculus had kind of softened and peeled away. So this is, again, before mechanical treatment. Will we go in and debride that calculus with beautiful instruments? Of course. But the important piece to know is that systemically, after 2 months of wearing only Perio trays, no mechanical therapy, and not only did the calculus soften, we see a beautiful resolve of that gingiva, but take a look at this. Their A1C dropped to a 5.8%, which tells us that being able to integrate custom Perio tray therapy may help control systemic markers. At an A1C of 5.8%, are we going to get a better outcome when we do the debridement on our patients? Absolutely. So this really changes the dynamic. This allows us to be smarter about our care and to think about treating this disease the way a periodontist does. How will this patient respond? What will get in the way of this patient responding successfully? How can I put tools in my patient's tool belt that will help them to respond more favorably? That's how periodontists think. And so now we have the opportunity to think like a periodontist. Okay, last case, I promise. This is Alice. Alice is 58 years old. She is a type 2 diabetic. She had her last physical exam 6 months ago. She's on metformin. She's adopted, so we don't know her family history. Her A1C is an 8.6%. That was taken 6 months ago. And she is a current tobacco smoker. She's been smoking a pack a day for the last 35 years. If we take a look at her images, so these images depict Alice's radiographs. We can see here that she has lost many teeth already due to the periodontal disease process. Probing depths of 6 to 7 millimeters, localized 9s, generalized recession, major areas of concern, generalized bleeding throughout the mouth. So the question here becomes, what is Alice's stage and grade of disease? What is her stage and grade? And I'm going to ask you to populate that into the chat box. Based on the data as we're seeing it, based on her diabetic status with an A1C of 8.6%, her tobacco use, based on the overt level of missing teeth due to the history of perio, as we can certainly see, the questionable prognosis of other teeth, based on the existing bleeding tendency that we see here, what is the stage and subsequent grade of disease for this patient? Well, let's take a look.
Alice's case is a common one, routinely treated in a periodontal practice. Here, we're observing generalized 4 to 8 millimeter periodontal pocket depths, sites of furcation involvements and mobility, and the radiographs demonstrate moderate ridge defects with vertical bony defects. In addition, she has many edentulous sites due to a robust history of periodontal disease. In addition, Alice is a type 2 diabetic with a hemoglobin A1C reading of 8.6% and a habitual tobacco user, smoking on average 1 pack per day. This classifies her as active periodontitis stage 4, grade C. I guess you all really are just as smart as a periodontist. But do me a favor, let's keep it between the hygienists. I can't have my perio colleagues knowing you all are just as smart as we are. I'm Dr. Timothy Donnelly, and this has been Are You Smarter Than a Periodontist? Thank you, and good night.
And with that, thank you so much for joining me, Katrina Sanders, and the amazing ACT dental community for the wonderful opportunity to be a part of this wonderful event. Again, if there are any questions along the way, please never hesitate to reach out. You can reach out to me at the Dental WINEgenist. And thank you so much, Angela, along the way for sharing that handout. It has been just a pleasure. With that, I'm going to turn the microphone and the screen back over to you, Angela, to provide concluding remarks and offer the CE credit detail. Thank you all so much for joining me today.
Thank you. That was spectacular.
My pleasure.
I loved it. I really loved the interaction and getting to play with the Kahoots. That was really fun. Thank you.
My pleasure.
And I also love that you use the chat, so everybody should be able to see their CE code right now. So, and I am going to share my screen. Here we go. So I've linked this form a few times. This was the place to get Katrina's handout there. And I'm also going to offer for you guys to join the Best Practices Association as a free member if you're not already. We will post the replay, and can we post your handout in there too for
Sure,
folks,
absolutely.
Katrina? Okay,
yep, you
awesome.
bet.
I'll do that later today once Zoom downloads it and everything. And like I said, make sure you find the chat again and get your CE credits for today. I'll just leave both of these up for a couple minutes here. Was there any questions that anybody had that they want Katrina to answer before we jump off? I know we went through a lot of them. Katrina, you're always awesome at answering everything that you see pop up.
My pleasure. Yeah, I want to make sure I was answering along the way.
The CE code is posted in the chat. Just kind of scroll up a little bit to see it. I'll post it again though, so it's handy.
I do have a good question from Rachel, if you don't mind me just sharing the answer here really fast, because this is a very common question for staging and grading.
Yeah.
Rachel asks, if the grading can be modified, how about the staging? Can the staging be improved? This is a really good question. The answer is it can, but it is quite rare, and it has to involve periodontal therapy where there is reconstruction being done, where we are getting bony regrowth or using growth factors, or laser assisted osseous where we are getting bone changes, if that makes sense. So a patient can go from like a stage 3 down to a stage 2, but that would mean that we would need to see those furcations close up, which means we'd have to have bony regrowth into those areas. So in your non-surgical, like hygienists, we were always taught we can't reverse periodontal disease. Well, hygienists can't, although we are seeing some modalities, by the way, just on a super side note, we're actually seeing bony regrowth when people are using like endoscopes and things like that by hygienists. So there's some interesting stuff going on out there. We would have to see bony regrowth, some kind of therapy that's being done in order to move that patient down from a stage 3 to a stage 2, for example.
Awesome. Thank you.
Mm-hmm.
All right. I'm going to stop sharing so I can see everybody again. There we go. Well, thanks everybody for coming out today and spending your Friday with Katrina and myself. And Katrina, thanks again. This is just spectacular that you spend so much time behind the scenes working out all of this so we can make sense of it. And I just appreciate you so much. So thank you.
My pleasure. And as always, thank you so much for inviting me to be a part of this.